Good morning. I would like to thank EACTA committee for this opportunity. I am Sara Tomasini. I work as an anesthetist intensivist consultant at the cardiothoraco-vascular department at Sant'Orsola Malpighi University Hospital in Bologna, Italy. In this presentation, I will address sedation strategies and neurological assessment in COVID-19 ICU patients, comparing literature review with our clinical experience so far. I have no conflicts of interest to declare. This webcast was peer-reviewed by Professor Stephen Rex. To begin with, I would like to point at the tremendous impact COVID-19 has had worldwide. These are pandemic's demographics on the 24th of May 2020. Data were obtained from World Health Organization Situation Report 126 and European Centre for Disease Control report. No cases of COVID-19 and further deaths occurred up to now. As the pandemic increasingly spreads, more clinical aspects are observed, studied, and shared. From its outbreak, we faced new pathological aspects of COVID-19, discovering its pervasive systemic effects and potential of long-term damage on human body. Soon, we realized that COVID-19 is an encompassing pathology. While at the very beginning of the outbreak, the primary focus was lung damage and antiviral therapy, it became clear there was more to be addressed. ARDS treatment and strategies for lung protection, such as careful airway management, ventilation therapy, proning, ECMO. There were safety issues and prevention of infection spread, choosing anti-infective therapies, which antiviral had to be adopted, treating superimposed infection, coagulation dysfunctions, immune system altered response, liver and kidney dysfunction. Special care was required in selected populations such as pregnant women and pediatric patients. But this isn't only about viral disease affecting lungs, which can eventually lead a patient to ICU and multi-organ failure. The brain is affected too in several ways. This virus has a potential primitive neurotoxicity which is still under investigation. Comparisons have been made with SARS, MERS, and other beta coronaviruses to understand potential neuroinvasivity of COVID-19. Moreover, brain health is affected by systemic general condition and therapeutic approach. Encephalic and peripheral nervous system damage can develop from multi-organ dysfunction, hypoxia, inflammation, sedation. Brain reserve is profoundly affected by ICU stay, leading to prolonged recovery time, potential permanent neurological damage, increased risk of death, psychiatric issues in patients and families. This is an overview of observed neurological lesions and incidents from a Chinese case series of 214 patients diagnosed with coronavirus 19. Overall, 36.4% had neurological manifestations. Patients with more severe infection were more likely to have neurologic involvement, such as acute cerebrovascular disease in 5.7% of cases, impaired consciousness in 14.8%, and skeletal muscle injury in 19.3%. Neurologic manifestations were divided into three categories: Central nervous system manifestations such as dizziness, headache, impaired consciousness, acute cerebrovascular disease, ataxia, and seizure. Impaired consciousness include the change of consciousness level like somnolence, stupor, and coma, and consciousness content, in particular confusion and delirium. Then we have peripheral nervous system manifestations such as taste impairment, smell impairment, vision impairment, and nerve pain, and skeletal muscular injury manifestations. In patients with CNS manifestation, the most common reported symptoms were dizziness in 16.8% and headache in 13.1% of cases. In patients with peripheral nervous system symptoms, the most commonly reported were taste impairment and smell impairment. There are few case reports of major neurological lesions, but the incidence of devastating clinical scenarios is still anecdotal. Analyzing the mechanisms of COVID-19 neurotropism, a few studies propose a double route of neuroinvasion, both neurally borne and blood-borne, affected by tissue distribution of angiotensin-converting enzyme 2 receptors in humans. SARS coronavirus 2 may enter the blood vessels through mucosa and infected lungs. Viremia, as seen in picture A and B, disseminates throughout the body via the bloodstream. Neurotropism may occur via circulation and/or via an upper nasal transcribial route, through the olfactory nerve endings and through conjunctiva. That enables the coronavirus 19 to reach the brain and directly infect neurons by binding and engaging with the ACE2 receptors on the surface of neurons. COVID-19 docks on the ACE2 via spike protein, as seen in picture D, the golden spikes. Axonal transport may promote rapid spread from neuron to neuron. Lungs, heart, kidneys, intestines, brain, and testicles are well known to express ACE2 receptors and are all possible targets of COVID-19. Mechanisms of neurolesion are several, involving virus-host interaction and host response. Cytokines secreted from infected neurons damage nearby neurons and glial cells. SARS coronavirus 2 binds to ACE2 protein abundantly expressed in endothelial cells, disrupting the blood-brain barrier and leading to cerebral edema and intracranial hypertension. After viral infection, human immune cells produce antibodies against this coronavirus. However, some autoantibodies also attack endothelial cells of the vessels and neurons, resulting in autoimmune encephalitis. Stress caused by panic or COVID infection causes the release of corticotropin-releasing hormone and the overactivation of the hypothalamic pituitary adrenal axis. Effector glucocorticoids and glucocorticoid receptors exhibit different behavior, increasing the susceptibility to environmental stress. At the same time, environmental stress causes epigenetic modification changes